President-elect Mr. Jayanta Galleheva, General Secretary Mr. Tissara De Silva, Treasurer Mr. Chandrasri Kalupahana, past presidents, office bearers, our distinguished guest speakers, members of the Executive Council and General Forum, delegates from member associations, ladies and gentlemen. I am delighted to welcome all of you to this seminar on the prevention of HIV/AIDS, tuberculosis and malaria, jointly organized by the Organization of Professional Association of Sri Lanka and Independent Medical Practitioners Association, with assistance from Country Coordinating Mechanism, Sri Lanka. These diseases merit our urgent attention as they represent a significant threat to public health. If we consider HIV/AIDS up to 2023, there have been a little over 1,500 AIDS-related deaths, with a total around 5,500 HIV patients being reported in Sri Lanka. A major health issue if effective prevention measures are not taken. Tuberculosis is the second leading infectious disease in the country after dengue. Around 7,000 patients are reported annually in Sri Lanka, with approximately 500 to 600 people dying each year. Of great concern is the fact that the WHO estimates that around 5,000 patients around undiagnosed in the country, leading to further infections of this disease. As such, it is a very serious threat whose spread must be urgently addressed. Sri Lanka is fortunately now malaria-free, a testament to the effectiveness of eradication program. However, we must be vigilant and prevent the reintroduction of this deadly disease, which was responsible for several lakhs of cases in the past. Having battled with this endemic illness for over a century, it is essential that we ensure that malaria is not able to gain a foothold in our country through imported cases. We are fortunate to have with us three very eminent experts as our guest speakers this evening, who will be able to tell us much more about these dangerous diseases. They are Dr. Vindhya Kumarapeli, Director, National STD AIDS Control Program; Dr. Pramita Shantilata, Director, National Programs, Tuberculosis Control and Chest Diseases; and Dr. Pubudu Chulasiri, Consultant Community Physician. I know that we will all be able to learn a great deal from your immense knowledge as well as your practical experience in combating these diseases. Your insights and views will enable us to better understand what must be done to address these dangerous threats to all Sri Lankans. It is my pleasure to welcome the President of IMPA, Dr. H.A. Hasare, and our moderator for this evening, Dr. Kanti Ariyaratna, Secretary of the IMPA. Thank you for volunteering to moderate this event today. The success of the prevention and control programs that the Ministry of Health has implemented will depend on the support and assistance of all stakeholders. We believe that the professional community has an important role to play in preventing the spread of these diseases. That is the very reason we have invited representatives from all our member associations to learn about the initiatives of the health sector and act as advocates and communicators in their respective organizations. Your presence will ensure that the professional community plays its part in addressing these serious challenges to public health. I am sure all of you are waiting eagerly to hear our great guest speakers, after which we will have a Q&A session where you will be able to get answers to any questions you may have. So let me now hand over proceedings to the moderator, Dr. Ariyaratna. I wish you all a rewarding and informative seminar.
The President of PA for the introduction and the kind words. May I now invite Dr. A.H.A. Hasari, President IMPA, to welcome the gathering on behalf of the IMPA.
President-elect and the Secretary of the OPA, the resource persons, and the moderator for this evening, Dr. Kanti Ariratnam, who is also the Joint Secretary of the IMPA, and she is the force behind this event. So she is the Country Coordinating Mechanism, head of the Country CCM, which is looking after AIDS, malaria, and HIV, AIDS, malaria, and tuberculosis for Sri Lanka. So I may like to introduce the IMPA. A lot of you all may know, there are a lot of IMPA members here also. IMPA is we are inaugurated in 1929. Actually, IMPA means independent. All the private doctors in Sri Lanka are members of the IMPA. Should be members of the IMPA, and it's supposed to be the oldest organization of private doctors in the world. And I think the GMO is a little older than that, and that was started in 1926. I think they'll be coming to 100 years in the next 1 or 2 years, and we'll be coming to 100 years in about 5 years' time. Also, I have thanking the OPA for having organized this today's program, which is quite important, and I think it should go not only to all the associations. We have about 50 over associations in the OPA and about more than 30 professions, yes, more than 30 professions. But actually through them, this message should go to the public and help the promotion of our prevention program. There's another very important program, not today, but we are hopefully do it in the future. There's a program called the Antimicrobial Resistance Program, which the IMPA is very much involved. It is, Ministry of Health is also very much involved in this, and the program is just being followed. It's called AWARE, A-W-A-R-A, AWARE, because antibiotics have been misused all over the world, especially not in Sri Lanka also, but all over the world. So they are unable to produce medicines and antibiotics to kill the germs. So that will be the next item. I think the IMPA will get involved with the OPA. And I won't take any more of your time, and I wish you all a happy evening. Thank you.
As every one of us are aware, we are gathered here for the event of establishing a network with member associations of organization of professional associations for prevention of AIDS, tuberculosis, and malaria. As already said by the President of PA, prevention and control of communicable diseases is one of the most important tasks in Sri Lanka, as they are still causing considerable amount of socio-economic loss to the patients, families, and to the whole society. Among the communicable diseases, AIDS, tuberculosis, and malaria are 3 diseases which needed much attention in the Sri Lankan context. Main objective of this event is to establish a network with member associations of organization or professional associations for prevention of AIDS, tuberculosis, and malaria. The specific objectives of the event is to establish a network with representatives of member organizations of OPA to create awareness on HIV, AIDS, tuberculosis, and malaria among the representatives of the member associations, and to obtain their services as advocates and as communicators in creating awareness among your own members as well. Hence, we consider this as an excellent opportunity for those associations to increase the knowledge, attitudes, and practices among their members to get the support in strengthening the prevention and control activities in HIV, AIDS, tuberculosis, and malaria. The Independent Medical Practitioners Association is the lead technical association in this, and had coordinated with the Organization of Professional Association through its Health and Nutrition Committee to organize this. This event is sponsored by the Country Coordinating Mechanism Sri Lanka, which is established as an integral part of the Global Fund Partnership, which brings a diverse group of stakeholders, including health and non-health governmental organizations, civil society organizations, and developmental partners to facilitate the implementation and monitoring of the grants. So we will start with the first lecture. As you all know, tuberculosis is a common illness in Sri Lanka, coming from ages, even from colonial period, and which needs many interventions in prevention and control. There is no other person than Dr. Shantimala, who is the director of the program, to talk about that. Dr. Shantimala is a senior medical administrator and a public health professional and currently holds the post of Director, National Program for Tuberculosis Control and Chest Diseases of the Ministry of Health. Dr. Pramita Shantilata holds degrees of Bachelor of Medicine and Bachelor of Surgery from University of Peradeniya, Master of Science in Community Medicine from University of Colombo, Postgraduate Diploma in Business Management and Master of Business Administration from Wimber University of Sri Lanka. She has nearly 30 years of experience in the field of health, ranging from curative health to public health and to medical administration. Dr. Shantilata contributes to the advancement of education by being a council member of the Wimber University of Sri Lanka. Dr. Shantilata, the floor is open for you.
Thank you very much for inviting me for this important forum. President OPA and President IMPA and Madam Kanti Ariyaratna and all the guest invitees and all the members of OPA. I am going to present you about the prevention and control of tuberculosis program in Sri Lanka. Outline of this program is about what is tuberculosis and how TB presents and the TB situation in the country and targets of ending TB epidemic and also existing strategies for the ending TB epidemic. What is tuberculosis and how TB presents? Tuberculosis is an infectious disease caused by Mycobacterium tuberculosis. That is an airborne infection. That means when a patient with tuberculosis, he or she cough, sneeze or sometimes laugh, the TB bacilli spreads as droplet. When a normal patient or a normal person is with TB patient, when he cough or sneeze, the TB bacilli spreads through the air, and when the normal person inhales, that droplets will go to the normal person's lung and can cause TB infection. What is about the TB infection versus TB disease? It is estimated that about 25% of the world's population has been infected with Mycobacterium tuberculosis. Tuberculosis infection is a state of persistent immune response to Mycobacterium tuberculosis antigens with no evidence of clinical manifestations of disease. So when person infected with Mycobacterium tuberculosis, all the people do not get the disease. Some of the people with low immune response, they will get the disease. That means people with TB infection have no signs and symptoms of TB disease. They are not infectious and have normal or stable images on chest X-ray and have negative microbiological tests if performed. What is TB infection? TB infection versus TB disease. Approximately 5 to 10% of people infected with TB bacillus but not suffering from any other concomitant immunodeficiency condition will develop the active disease during their lifetime. Majority, that means 90 to 95% of will not develop the disease, and only evidence of infection in the people may be a positive test of TB infection. The chance of developing the disease is greatest within the first 2 years, and lessons at time goes by, but the risk probably remains for the lifetime. Sometimes when they infected, but the disease will not occur, but the lifetime the infection will remains their body. Weakening of the immune response can cause rapid progress of the infection to the disease status. Examples: when the people have HIV infection, chronic kidney diseases, diabetes, malnutrition, when the patients are on prolonged prolonged steroid therapy, chronic alcoholism, and on malignancies, they are more prone to the TB infection. About the TB disease, 75% of the TB cases are pulmonary TB. That means the lungs are affected with tuberculosis. Usually we think that TB affects only for the lung, that means the pulmonary TB. But 25% of all cases are extrapulmonary TB cases. That means except nails and the hair, each and every organ can be infected with tuberculosis, mainly brain, lymph nodes, bones, skin, eyes, kidneys, all the places TB infection can get. Following categories are the high risk of developing tuberculosis. The contacts of the pulmonary TB patients. When the patients are sometimes households, sometimes when the child has the infection, all the children are prone to get infected, or sometimes the person are in the workplace. If they get tuberculosis, the people who are around this can infected with tuberculosis. That means the contacts of the pulmonary TB patients are high risk of developing TB. Other than that, health workers, undernutrition, immunocompromised patients, those who are on immunosuppressive therapy, and the patients with chronic diseases, that means diabetes, chronic kidney disease like patients, and elderly people and institutionalized persons are more prone to, that means high risk groups of developing tuberculosis. The common symptoms of pulmonary tuberculosis, mainly the respiratory symptoms. Cough is the main symptom of having tuberculosis, usually more than 2 weeks of cough. However, in immunosuppressed and in the presence of any other risk factors, cough of any duration should lead to the screening for the tuberculosis. Other respiratory symptoms are shortness of breath, chest pain, and hemoptysis, that means blood-stained sputum. Other than that, the constitutional symptoms may be fever and night sweats, loss of appetite, loss of weight or failure to gain weight in case of children, and tiredness. And there may be any other symptoms also. When a person suspects with tuberculosis, that means we tell it as presumptive TB patients. Sometimes the patients come to our OPDs, and sometimes maybe to the general practitioners. They come as following above symptoms that I mentioned earlier. When a patient comes to our clinics, there are diagnostic algorithms for tuberculosis. Mainly patients with signs and symptoms of suggestive of TB, that means pulmonary tuberculosis, we do usually 3 sputum samples for the acid-fast bacilli, and also we do chest X-rays. When we diagnose the patient as suggestive as tuberculosis, we send these patients to the chest clinics for treatments. There are these slides you can see diagnostic algorithms for the TB adult patients, and also there is another algorithm for the pediatric TB presumptive patients. Not only cough and symptoms like as mentioned above, pediatric TB patients, pediatric TB children presents with any other symptoms. Usually persistent fever more than 2 weeks without a known cause, unremitting cough more than 2 weeks, weight loss, poor weight gain, pneumonia not responding to antibiotics, sometimes poor control of asthma or wheezing despite of appropriate treatment, and fatigue, lethargy and decreased activity. Those may be the symptoms of children who is having TB. There is a different algorithm for the pediatric TB patients. We have given these algorithms to all our district chest clinics and all the OPDs. When the patient comes with this type of symptoms, they can use this algorithm to diagnose the TB patients. What is TB situation in the country, our country? This slide you can see the TB notification from 2010 to 2023. As you all can see this slide, according to that, until 2010 to 2015, there is a static amount of TB patients. You can see from the top line, all cases, second line, all new cases, third line from new pulmonary TB cases, red line, new pulmonary bacterial confirmed cases, and lower line, new extrapulmonary TB patients. Extrapulmonary means other than the lungs. Extrapulmonary TB patients are little static from 2010 to 2023. But up to 2015, the number of cases are little static from 2010 to 2015. After that, you can see there is a gradual reduction of TB patients until 2019. But during COVID-19 situation, the number of patients have become low. You can see in 2020 we have diagnosed about 7,058 total patients. In 2021 we have diagnosed 6,771 cases. But after that we were able to do our diagnostic facilities expand, and we were able to come to the level as 2015 level. In 2023, we have diagnosed total 9,538 cases. But according to the WHO estimate, we wanted to diagnose more than that amount of cases. As mentioned earlier, WHO estimation is we have to diagnose 62 per 100,000 people. That means we need to diagnose about 14,000 patients per year. But in 2023, we were able to diagnose 9,538 cases. That means we are missing about 4,500 cases of tuberculosis patients. That is the problem that we have. We are diagnosing about 42 patients per 100,000 population. That is why we need to aware about the tuberculosis. We need to diagnose the tuberculosis patients. We need to treat those patients to eliminate the tuberculosis from our country. That means you can see the case detection rate. we are missing about, in 2022, we are missing about 5,800 cases. In 2023, we have missed about 4,700 cases. The missing population may be 33%. This is the situation about TB cases in our country according to the districts. You can see Western Province, that means Colombo, Gampaha and Kalutara. These districts are the highest number of cases we can see. Out of 9,508 cases, 46% of patient national burden is from the Western Province. Out of that, Colombo district have 25% of national burden. Out of that, CMC has about 50% of Colombo cases. That is the problem. The people who are living in Colombo, most of them are high risk on tuberculosis. We have diagnosed 2,348 cases from Colombo, from Gampaha 1,311 cases, from Kalutara 703 cases. In other districts, there's a reduction. You can see some less numbers, but Kandy, Kurunegala, Galle, Ratnapura, Galle are high-risk districts other than Colombo district. The case notification is also same. You can see Colombo is high risk. The distribution of the tuberculosis cases in Colombo district. I have mentioned earlier 2,348 TB cases from Colombo district. 58% is from Colombo Municipal Council area. That means 1,132 cases. That means the incidence is around 174 cases per 100,000 population. I have mentioned the Sri Lankan situation should be, according to WHO, 62 per 100,000 population, but in Colombo municipal area, we can see 174 patients per 100,000 population. Then these are the areas according to the CMC area, D1, D2A, D3 areas. That means Modara Mattakuli area, Grand Pass and New Basa area, Borella Vanathamulla and Dematagod area, the high risk areas in Colombo municipal area. This is about the gender distribution of TB patients. You can see in early childhood, that means in less than 15 years of age, female patients are higher than the male patients. But when growing older, incidence of male patients are higher than the female cases. That means in childhood, male distribution is 1.2 to 1 female to male ratio. In old age, 1 to 1.8 female to male ratio. That means males are high risk than female in old age. Those may be alcoholism, smoking and so many things, high risk factors. According to the gender distribution, you can see Sri Lankan situation and Colombo situation and CNC situation. You can see high risk, the female and male ratio is sometimes little equal in the CNC area. And the age distribution, as mentioned earlier, more than 15 to 24 years of age, 50% of 55% of population is contributing to the TB, but old age is high risk. The pediatric tuberculosis cases. Usually, we wanted to diagnose. We are a low middle income country. The estimation is about 5 to 15% of the total cases. There should be pediatric cases. But we diagnosed less than that. Only 2.3% of pediatric cases we have diagnosed. During 2023, we were able to diagnose about 215 pediatric cases. That is also less number of cases we diagnosed. This is about the TB HIV co-infection. You can see TB HIV co-infection. That means TB cases having HIV disease and or HIV cases having TB disease. You can see about 43 people are having HIV and TB co-infection. And also there are drug-resistant TB cases. Usually, if Sri Lanka is not the threat for drug-resistant TB, but we have diagnosed in 2023 28 drug-resistant TB cases. Multi-drug resistant TB cases numbers are higher in Gampaha district and Colombo district are the risk area for multi-drug resistance. These are the major risk factors for the tuberculosis. Most TB patients have one or more comorbidities. Smoking, alcohol use, underweight, diabetes mellitus and contact history are the major risk factors for tuberculosis. As mentioned earlier, TB is the major cause of death among infectious diseases. During 2023, we had 747 deaths out of total cases. That means out of 9,538 cases, we had 747 deaths. That means 9% of cases deaths we can see. What are the NTB targets and the current situation in relation to NTB targets? These are the NTB targets. That means SDG targets and the NTB targets are there. SDG targets are due to the 2023. NTB targets are for the 2035. These are the indicators for the TB targets. Percentage of reduction in the absolute number of TB deaths. Number of deaths should be reduced up to 95% than the according to the baseline of 2015. And also incidence of TB should be reduced up to 90% and there should be zero catastrophic cost. These are the TB targets. In 2035, we have to reduce TB deaths up to about less than 50, that means about 32. And the incidence should be 6.5 per 100,000 population and there should be zero catastrophic cost. That means the people or family should not have cost for the tuberculosis patients. These are the existing strategies for the NTB. As I mentioned earlier, we have to reduce the TB incidence. For that, we have to improve the TB case findings. For that, we have prompt diagnosis of TB at first contact and we have to do active case finding by screening of high-risk groups. And the second thing is to prevent emergence of new TB cases. For that, we have to treat for the TB infection, that presumptive latent TB patients. That means we want to screen the TB patients. If we can do skin test can be done. If it is positive, we can treat this patient without having TB symptoms. This is for the things that we can do to reduce the number of deaths. We need to prompt early treatment seeking. For that, community empowerment can be done, community engagement can be done. And we have to manage TB and TB with comorbidities. I have mentioned earlier, most of the TB cases have one or more comorbidities. We have to treat all the TB comorbidities and we need some inward care for the needy patients, and also the treatment we can treat with DOTs, that means directly observed treatment method. This is the prompt the thing that we are doing for the prompt diagnosis of TB patients. There are 26 district case clinics in our country and we have 100 branch clinics and also we have 100 microscopic centers. As mentioned earlier, I have informed TB can be diagnosed by sputum examination and we have given training for the primary care providers. And also we have National TB Reference Lab for the provide advanced diagnostic facilities. And also we have the world recognized diagnostic facility is the gene expert and the TrueNut. Through that we can have diagnosis can be done, and also the multi-drug resistance can be diagnosed. And X-ray facilities, we have given X-ray facilities to all district chest clinics to improve the case finding. To increase the active case finding, that means we have to go to the public or high risk areas and we need to diagnose these patients. Active case findings can be done through screening of the close contacts, and also mass screening can be done for the prison inmates. Mainly prison people have more risk of having tuberculosis, and also, as I mentioned, elderly patients, we have to screen elderly population, and we have to screen all HIV patients, and we have to screen drug addicts, and also we have screened the high risk community. And also the treatment can be given, as I mentioned earlier, latent TB. That means TB preventive therapy. Before getting the TB infection, before having TB symptoms, we can treat the patients who is having tuberculosis. Mainly HIV patients, we screen these people. If they are suspects for tuberculosis, we can treat these patients with TB preventive therapy. And household patients also, we can treat those. We have to do high risk patients and latent TB patients. That means without symptoms, having tuberculosis, we can treat by TB preventive therapy. These are the other strategies. Those are multi-stakeholder engagement. That means health people and non-health people all can engage and all can aware about the tuberculosis. They can help us to send, if the people are having symptoms like tuberculosis, that cough and cold and other symptoms, you can send the patients to the nearest chest clinic, for the nearest chest clinic, sometimes nearest hospital, to diagnose these patients. And also there should be social protection. We are giving some allowances to the TB patients. According to the provinces, the allowance may be vary. Sometimes they are giving 5,000 rupees per month. Some districts they are giving about 500 rupees or something. But it is very necessary. Nutrition is the very important thing to these patients. We need to give some allowance to TB patients, and we are giving some 2 packets of Triposha for the patients per month. That is not enough. That is very important. If some NGOs can give some packages to these people, that is very important. And the engagement of community and community-based organization, that TB referrals for the dot provision, NGOs can help to diagnose and treat the patients. Because of that, we will be able to, early diagnosis is important, prompt treatment is very important, because by doing this, we will be able to end TB in 2035. Thank you very much for giving the opportunity to aware about the TB.
Now it is the time to come to listen to about HIV/AIDS. HIV/AIDS situation is increased alarmingly in recent years, especially making the young people at risk. I'm not going to talk about the data because the director is here with us. Reported data indicates that the young within the age of 15 to 24 are at risk. So it is the time we will listen to the director. Dr. Vindya Kumarapeli is a specialist in community medicine and a senior medical administrator, currently holding the post of Director National STD AIDS Control Program and the Director Policy Analysis and Development of the Ministry of Health, Sri Lanka. Dr. Kumarapeli holds the degrees of Bachelor of Medicine and Bachelor of Surgery, Master of Science in Community Medicine and Doctor of Medicine in Community Medicine from University of Colombo. She has nearly 20 years of experience in community medicine, in public health that has evolved over the years, enriched with technical excellence obtained from Sri Lanka and abroad. Dr. Kumarapeli received her postdoctoral training at the Harvard School of Public Health, USA, in 2008 to 2009. She was also a research fellow of the Global Burden of Disease Group, School of Population and Global Health, University of Melbourne, during 2017 to 2018. She has contributed to the advancement of education and research through the supervising of postgraduate trainees in community medicine and medical administration, with numerous publications to her credit in peer-reviewed journals. She is the president-elect and an honorary fellow of the College of Community Physicians of Sri Lanka. Her scientific contributions have been recognized as a recipient of the President's Award for Scientific Publication twice, that is in 2010 and 2012, and the National Science and Technology Awards in 2010. Dr. Kumarapeli, the floor is open for you now.
Good evening to all distinguished invitees, ladies and gentlemen. Thank you very much for giving this opportunity to me and also to the national program. So I would briefly take you through the current trends and status of HIV/AIDS situation, and also the priority areas in prevention and control and role of the different professional groups in strengthening the activities. So there are former directors also in the audience and former presidents of the college, so I am sure they know better than me. So the campaign was started as the anti-venereal disease campaign in 1952, and it has evolved over the time as the National STI and AIDS Control Program of Ministry of Health Sri Lanka. And we are the coordinating or the focal point for the national response to prevent and control sexually transmitted diseases, including HIV and AIDS in the country. So the program goal is to end AIDS epidemic as a public health problem in Sri Lanka by 2030. So if I briefly go through the epidemiology of HIV and AIDS in our country, actually, for the audience who are not non-medical, maybe I should briefly describe the difference between HIV and AIDS. So HIV is the virus, the human immunodeficiency virus, which attacks the immune system of the body, and AIDS is the disease condition, acquired immune deficiency syndrome, and a group of diseases caused following severe loss of our body's immunity due to this HIV virus. So if we look at the data from the first local case diagnosed in 1987 up to last year, these are the published data from the national campaign. So the number of cases or the newly diagnosed people with HIV have been increasing, and I don't know whether you can see it clearly the year. For example, if we look at 2000, maybe 18, 19 or 2020, we had around 350 newly diagnosed HIV infections. But last year and year before, we have had more than 600 newly diagnosed cases. Actually, in 2023, that is last year, we had nearly 700 newly diagnosed HIV infection, which means there's almost double number of new cases of HIV last year. And when we look at our modeling and our estimates, we estimate that there are about 4,700 people living with HIV. However, when we look at the data collected over the years from the first local case, there have been over 5,000 people diagnosed with HIV, and there have been some deaths and lost to follow-up. So by now, there are about 3,400 patients living with HIV under our care. That means registered with us, which includes 40 pediatric patients. Although we have highlighted the increase in the number of cases, Sri Lanka is still considered a country with low risk of HIV, because in the general population, when we look at the numbers and divide by our population among adults, the prevalence is less than 0.01. That is the reason why we are considered among one of the low risk countries. So these are the estimates, and but this slide I would really like you to understand and sort of look at the data very carefully. The green line is for children less than 15 years. So green line, although you may not see the year and the number exactly, but you can, I'm sure you can see the green line. It has been static, I would say static throughout. Those are the children. So we don't see much of an increase, alarming increase among children. The grey line is, of course, women 15 years and above, and that has also been kind of static throughout the year, starting from 2010 to 2023. But if you look at the red line, those are men age 15 years and above. You can clearly see that the cases, new cases detected are increasing among men adults. And I have the same data presented in a pie chart. The blue one is males, and the red color one is females. And far back in 1996, male-female ratio had been 2.2 to 1. 2 male to 1 female, but according to the latest data, it has been 7 to 1 ratio, 7 males to 1. And now this is the gender distribution. Then the other one I like to highlight is the particular age group, the youth, 15 to 24 years. I don't know whether it's very clear. I can explain it. Again, even among men, the increasing line is males 20 to 24 years. I'm sure you can see the increase, the red line, that is males 20 to 24 years. So that is something that we have to be concerned. So that means the number of new cases are increasing among youth. We can clearly see that even in the data we have up to the third quarter. Now we have analyzed up to the third quarter, we see the same situation in the 2024 data. And if you look at the geographical distribution, you can clearly see, yes, Dr. Pramita mentioned it's same for TB and HIV, I suppose. The Western province has the highest density. Of course, the population density is also there as a reason, but the coastal area is highlighted, Putlam, Galle, Matra, Hambantota, and of course the Western province as high density areas. And when we look at the transmission, it's mainly the unsafe sexual practices, either vaginal, oral or anal. Then we have mother-to-child transmission as a mode of transmission, and of course by infected blood. When we further look at the transmission among males and females, because I talked a lot about having it high in males, so we have to look at the data separately among men and women, among how the transmission occurs, and among female it's mainly heterosexual transmission. 97% of new cases last year among women were heterosexual, whereas when we look at data among men, majority is male to male sexual activity. Men having sex with men, or MSM, is 62% of the transmission. So that is something that we have to, if you want, we can discuss further. The same trend is presented here. The red one is the male-to-male sexual transmission. We call them MSM. Now they have become, the MSM mode has become the predominant mode. It was, you can see, in 2019 it accounted for 46%. Last year it has accounted more than half of the cases. However, heterosexual transmission seen in grey is also high, but there's a decreasing trend. Mother to child transmission is, of course, we have, I will talk about it later also, mother to child transmission of HIV has become very low, and we have even obtained certificates for elimination of mother to child transmission. So, along with the HIV cases, we have seen the same trend among other sexually transmitted diseases also. Here you can see syphilis. Again the same trend, among the highest among increases among male more than 25 years. Then congenital syphilis, gonorrhea, I would say the same trend, genital herpes and genital warts. So about mother to child transmission, we have our program about testing all pregnant women, and as a result we have been able to detect the cases early and treat the pregnant women early. As a result, transmission from mother to child is very low in our country. So very briefly I will talk about our national response. Now that you have seen the data, what is the national campaign doing to control this disease status? We also have our global targets. We call them 95 targets. So as I mentioned earlier, we estimate that there are about 4,700 people living with HIV, and we have to detect 95% of them. So far our percentage is 88%, which means we have been able to diagnose 88% of people living with HIV. Once we detect a person, we have to start treatment. So, but sometimes we may not be able to continue or continue the treatment although we detect them, because some of them may default. So, among identified persons, we have been able to treat 81%, which is fairly good, although it's not 95. As a result of early initiation of treatment, we prevent transmission to other people. And once on treatment also, we have to make sure that their viral load is suppressed. That target achievement is 86%. In general, we are actually happy with our targets, achievement of our targets, because we see there's an increasing trend. So our campaign works not only with the departments or the directorates of the Ministry of Health, we work a lot with other ministries. We need the support of multi-sectoral partners to carry out our program. So it's obvious that we need to partner with government organizations and also various other non-governmental organizations. We do work a lot with non-governmental organizations because the main reason is that why we work a lot with non-governmental organization is it's due to the nature of the disease. Sometimes the people with high risk behaviors or people living with HIV, due to the stigma and discrimination, they may not claim themselves as such. So we have to get the help of the non-governmental organizations for tracing, contacting people, high-risk people, case detection, referral, etc. So it's a little different model from the conventional model of delivering services through the midwife or the PHI. We do have their support for certain segments, but we have a very unique program where we get the support of the NGOs. If I briefly summarize the national response, it has two main components, the prevention part and the curative component. So curative component, I will first describe it. We have the testing program and the treatment campaign. But I like to draw more attention on the prevention activities. For our campaign has actually 4 preventive components. First one is the behavioral component. We target general public as well as high risk people on creating awareness on safe sexual practices, and we also distribute condoms and lubricants, and we also promote people to seek care, to test themselves and to seek care if they are high risk. The second one is the biochemical intervention. Now this was started in 2019, and as a campaign we are promoting the biomedical prevention also. There are 2 components: pre-exposure treatment or prophylaxis and post-exposure prophylaxis. So now we provide pre-exposure and post-exposure prophylaxis for high-risk situations. For example, pre-exposure prophylaxis is given to high-risk individuals like MSM because of their high-risk behavior in situations where they do not prefer to use condoms, and after consultation, after seen by the consultant or at least a medical officer, we registered those high-risk people and provide this pre-exposure prophylaxis. It's just 1 tablet per day. For 1 month we give the first prescription and continue throughout. Then post-exposure prophylaxis is also originally started for occupational exposures like needle prick injuries, but now since 2 years we are providing post-exposure prophylaxis within 72 hours of a high-risk sexual exposure, again on prescription after seen by a consultant or a medical officer. It's not freely available in the market, it's not available in pharmacies, it's not available in the private sector also. It's exclusively provided by the national campaign at the moment. Again, due to we have concerns about drug resistance also, so at the moment it's closely monitored by the campaign. Then I described about the EMTCT program, where it's also part of our prevention activities, where we provide screening free of charge to all pregnant women registered in our maternal and child health care clinics, and then try to detect the disease early and treat the detected pregnant mothers and also treat the newborn child. So these are the main preventive services. In terms of testing, I like to also mention that in addition to the testing provided at the clinics, we have our own website where there's a chance to order the test kits, the self-test kits, and then we courier them to the people who request it free of charge, and that is also another way of promoting testing so that we can get the disease early. All these are done because we have kept our prevalence very low. We are a low risk country because we have put a lot of effort on prevention and early detection and also treatment. But at the same time, we also we have realized the stigma and discrimination associated with people living with HIV, their families and their associates. So we do have a lot of programs for prevention of stigma and discrimination also. So HIV testing, I talked about it. We have the rapid test, the lab-based test, as well as the self-test. So that is promoted, and as a result, we do conduct more than 1 million tests per year throughout the country, and that is one way of early detection. And if you look at this data, I don't know how clear it is. There have been, I just thought I'll talk about this because there have been a lot of social media posts also about having infected, blood being infected with HIV. So we have tested more than 400 blood samples, blood donations, and only 56 patients were found, people were found to be positive with HIV with a prevalence rate of 0.01%. So we target our programs mainly to high risk people. We call them like they are called key populations. You can see the key population, and I'm sure you can by going through the epidemiology, the trends and everything, you must have realized the high risk populations, the sex workers. Now it's only not only female sex workers, so there are male sex workers also, so we call them sex workers, men having sex with men, transgender populations, people who inject drugs, although it's not a big problem. There are certain populations that use injectable drugs, and then prison inmates are known to have this behavior, high risk behavior and the infection. Beach boys segment is conducted in certain parts of the country, and there are other vulnerable populations like people who return from migrants who return from overseas work, armed forces, tourist industry, etc. Because our prevalence is very low, we target our programs to high risk population. That does not mean we are neglecting the general population. We do have, but our efforts, especially the global fund donations and everything, is more targeted towards high risk populations. Then finally, we offer our services throughout the country. In terms of universal healthcare, we do have a clinic in every district. Altogether, we have 40 clinics, and in 32 clinics, we have a consultant or an acting consultants, and anyone can walk in. Sometimes it's through appointments, but everything, the testing, treatment, and the prevention, the condoms, everything is provided free of charge by the government, and the campaign purchase the drugs, reagents, test kits, everything, and delivers throughout the country. So that those are the main segments of the campaign, and I'm happy to answer any questions. Thank you very much.
Marapeli, for your very informative and attractive presentation. And as we can see, it's a very target-oriented, tailor-made program which is going for the more high-risk people. Now we are going to talk about Sri Lanka's success story. Sri Lanka has eliminated indigenous malaria, which means the country does not have the malaria patients primarily originating from the people living in the country. However, Sri Lanka is still at a risk of getting the infection through travelers who are traveling to and traveling from countries where malaria is prevalent or endemic. And by this year, there were 8 imported cases. So it is, time has come to listen to the consultant from the malaria prevention program. He holds a Bachelor of Medicine and Bachelor of Surgery, a Master of Science in Community Medicine, a Master of Science in Applied Statistics, and a Doctor of Medicine in Community Medicine. And all his degrees were from University of Colombo. Dr. Chulasiri has nearly 17 years of extensive experience in public health, which has evolved through diverse roles. He has made significant contributions to the prevention and control of communicable diseases through his work at the Epidemiology Unit of the Ministry of Health and the National Dengue Control Unit of the Ministry of Health. Dr. Chulasiri underwent postdoctoral training at the University of York, United Kingdom, from 2016 to 2017, and served as a visiting research fellow at the same institution. He has contributed significantly to education and research as a supervisor for postgraduate trainees in community medicine, and as an author of numerous publications in peer-reviewed journals. He has also held notable positions within professional organizations. Dr. Puvdu Chulasiri, the floor is open for you now.
Good evening, you all. First of all, I would like to thank the president of the OPA, Organisation of Professional Association, and the members of this OPA. And especially I would like to thank Dr. Kanti Ariyaratne for giving me this opportunity to speak you on a very important aspect of health condition in Sri Lanka that we have already neglected. Because from the topic itself, it says, are we at risk of malaria again? What does that mean? Because are we having malaria? If I ask you, are we having malaria? What would be the answer? You can give yes or no. I will later tell you why I am telling yes and why I am telling no. So, why we are talking on malaria? I will present you 3 case scenarios, and it will open our eyes on the importance of thinking on malaria. The first case, actually this person, a 23-year-old male, and he went to Cameroon. Actually he was a gem trader, and he stayed there for about 1 month, and from there he had some illness, fever, fever and chills and headache. And after came to Sri Lanka, usually what we do is we just go to our general practitioner, first contact of healthcare person. So after 3 days, he just went there, and he had said, "Doctor, I have been to Cameroon also, but unfortunately, he was not tested for malaria, because whenever a person these days come with a fever, mainly we think about dengue or any other diseases." So second, since he had no improvement, second again he had gone to another doctor, and again same results. But after that, since patient was not getting better, he had gone to a consultant, and fortunately the consultant was one of our members of our stakeholder group. Then he asked for malaria testing. You can see that after the first contact, it took 10 days, around 10 days, him to be diagnosed. Totally preventable and not excusable, 10 days. Okay. So then he was found positive. Yes, he was treated well. And next, the second case. A 37-year-old, again a gem trader from Kalutara. Actually, he had go to Tanzania for some kind of gem business, and he stayed there for 7 weeks, and he just came to Sri Lanka. While he was coming, he had some illness, and same day he had gone to a doctor, and he got some treatment, but for those 5 days, he had abdominal pain, body aches, shortness of breath, all the features. He was even underwent for the ultrasound scan for the abdominal pain. Even though he went to Tanzania, no doctor, because he had gone to 3 doctors, and no doctor suspected, could this be malaria? But at the last time, since he was getting worse and worse, he went to a private hospital, and he was got admitted since he was very severe, and just 5 minutes before the patient died only, we were informed that patient was positive for malaria. At least we would have, if we were informed around 1 hour earlier, we would have given at least one shot of drugs. But unfortunately, only 10 minutes earlier we were informed, then later we were informed that patient died. So whose fault? Patient? No, he came on foot to the hospital. So it's not excusable at all. The first death, that was the first death after 2007. Okay? After 2007, it was the death occurred because of malaria. And after that, we just had many programs and we issued many circulars. If you suspect malaria, please suspect malaria, and if you suspect malaria, please test it. And we just did many programs, but this year, that happened last year, this year, again another patient, 47-year-old male, he was also from Kalutara, a sea merchant. He went to Guinea and stayed there, and he came here. After coming, he had fever, but he just stayed for 7 days without going for any doctor. But after going to the doctor, at the first time, whenever he went to the first doctor, the doctor requested the malaria testing. And it was done in private sector, it came negative. So negative means malaria was negative. So, but patient was not getting better. He was repeatedly getting admitted, even since he was not well, he got admitted to the government hospital as well. But since that test was negative, it was not repeated, thinking that okay, no, malaria is negative, so we don't need to test, we'll think about other disease. So by thinking, patient got fits and he was admitted to the ICU, and another doctor suspected, could this be malaria even though test negative? Then he was tested again. Only then he was positive. We were informed, we went there, we started the treatment, but the train has gone. So the second death in 2 consecutive years. Okay? So that was the issue. So whose fault? That patient also came on foot to the hospital. So is it excusable? You can see this slide. 23% of the patients are diagnosed after 7 days of the first contact. That means after went to a general practitioner, 23% of the patients are diagnosed after 7 days. They are not being suspected. So why I am talking these things? You can see that in once upon a time, there were lots of malaria cases. I think you can witness. You might have treated. And in 1930s, there were lots of deaths. But after mainly the 46, the number of cases reduced, and 1963 it came to only 17 cases. So usually what happens? Whenever the cases are getting down, our attention for this disease getting low and low. What happened? In 1967, again the outbreak started. It lasted for 40 years to make it 0 cases in 2012. 2012, this means the people who are getting disease malaria from this country, we call indigenous cases. 2012, the last year that we got indigenous cases. After that, no more indigenous cases. So WHO gave us in 2016 malaria elimination certificate. Only, other than Sri Lanka, only 2 other countries which have got malaria free certificate within Southeast Asian region. Only, what are the countries? What could be the countries? Maldives and Singapore. That means if all the other countries, Vietnam, Thailand, Malaysia, India, Pakistan, all the countries are endemic for malaria. Endemic means malaria is there. That means if you are going to these countries, you can get malaria parasite from these countries. Malaria is caused by a parasite, and if you go to these countries, you can get malaria parasite into your body. What happens? Sometimes you don't get malaria, the features in this country. So you return to our country, and after coming to our country, you get features of malaria and present as malaria patient. Why do we go to these countries? Mainly as gem traders, we go there. And peacekeeping, for the peacekeeping missions, lots of our people going to South Sudan, Central Africa, and sometimes for the tourism. And there are lots of government sectors now established in this African region where the malaria is there. So you can see that only Sri Lanka is green around the equator. All the other countries, the countries which are marked as white, are malaria endemic country. So if you happen to go these countries, you are at risk of getting malaria. Okay? So, yeah. So this is the situation. Even though we have no indigenous malaria, indigenous means we don't get malaria from Sri Lanka, but still there are around 40 to 50 cases are being reported in each year. Last year we got 62 cases, and this year so far we have got 34 cases of malaria patient. That's why I say we can say we have no malaria because we have no indigenous malaria, but in every year we are getting imported cases. So what is the issue of having imported cases? They come, they get diseased, and we treat. What is the issue? Because even though we eliminated malaria, we have not killed the vectors. Malaria is spread from one person to another by a malaria mosquito. Unfortunately, except in Colombo district, in all the districts, malaria mosquito is there. So if you present as a malaria patient, you can spread the malaria to all of these people through this vector. That is the issue. This is not common to the USA, UK, because they don't have malaria mosquito. But here we have the malaria mosquito. So we are getting cases, and especially we know that there are some strains of malaria where we can have severe form, especially we call it Plasmodium falciparum parasite, a strain of parasite. It affects the brain, and people tend to die. Before the COVID, usually the parasite was not virulent, but after the COVID, mostly now we are getting severe cases. So there is high chance of having severe malaria cases and deaths as well. The other thing, most of the cases are being reported from the western province. Why? Most of the people from this area, Colombo, Gampa, Kalutara, they are the people who go to these countries and get the parasite and come back and present as malaria patient. That is the issue. So, what can we do? As doctors, as general population, what can we do to prevent this condition, to get in these imported cases? First thing is, we cannot prevent migration. We can't ask people not to go to malaria endemic country. First thing is, if the most crucial thing is, when they come to Sri Lanka, we can diagnose them early. Like if they come to a doctor, if we suspect early, we can diagnose them early, we can treat them early, then there is lesser chance of spread. So how do we diagnose? We have guideline, and clearly we have asked, okay, what could be how to identify malaria patient, how to diagnose, like there are testing available in almost all the hospitals, especially the government hospitals in Sri Lanka, cheap, and not cheap mean free of charge. We do it free of charge, and it's very simple test. So by this testing, we can diagnose within 2 hours time. So if someone suspect having malaria, we can go to the government sector hospital even at the night. Even if you go at 2 o'clock in the morning to the government hospital, we, anti-malaria campaign, arrange your testing and get the testing done within 2 hours time. So don't worry, don't wait until tomorrow morning. We can test it at the hospital. But the issue is, we have to do 3 consecutive times. Like death, only once it was done. But you cannot exclude malaria by doing only a single test. You have to do 3 consecutive days to exclude malaria. And if you suspect, please inform the headquarters that there is a hotline. If you contact the hotline, we will arrange all your hospital admission. We will advise you what to do, where to go, all the information we will give on this condition. And we have enough drugs. We have kept the anti-malaria drugs in each and every hospital. So we have made sure that the drugs are there. Drugs are free of charge. Even you admit to a private hospital under a consultant, the treatment are given free of charge by the anti-malaria campaign. So don't worry. I know that you are not worrying about the cost, but the anti-malaria drugs are free of charge. The third, prevention is better than cure. We know how to prevent malaria. The best thing is to prevent mosquito bites, but not practical. That's why there are very good drugs to prevent drug. Very good drugs. So if you get it before you go to these countries, more than 95% chance that you will protected from the malaria. So there are drugs. If you go to India or Pakistan, you have to give separate drugs. If you are going to Pakistan and all the other countries, you have to give separate drugs. But the main issue is you have to get it in advance. If you are going tomorrow, don't come today and ask, doctor, I am going to this country, please give me drugs. No. The drugs should be taken 1 week in advance. So that's why we have to give the message. If you or your relative or your friend is going to this country, you have to get these drugs in advance. And these drugs are not available in the pharmacy. These drugs are available in the anti-malaria campaign, where you may be knowing, it is in front of the Lanka Hospital. There is a 7-storied building in the 3rd floor. It is being given from 8 a.m. to 4 p.m. And if you happen to come even in the weekend, we will arrange you to give drugs. If you are not in Colombo, there are regional officers in each districts in the malaria campaign. You can go there and just get the drug. So there is a hotline, I just mentioned you, I just put it again. You can contact that number and ask the drugs. That is second one. The third one, you cannot donate blood within 3 years after going to this malaria endemic country. That means if you go to India, you cannot donate blood for 3 years. If you go to Africa, you cannot donate blood for 3 years. Fourth one, yes, this is the main important thing, awareness of health staff and the general public. We have to improve, we have to increase the awareness of this general public, because it's not only for the doctors, even for the others, professionals, because there are lots of other professionals who are going to these countries. So we have to increase awareness. Please, if you are going to any malaria endemic country, please take the drug. And if you, after coming here, if you have fever, any other features, body aches, headaches, within 1 year after coming, it could be malaria. So you have to get tested. So other than that, we are screening, because sometimes we have got many malaria patients, no features, no symptom at all. They are completely healthy, but in their body, the malaria parasite is there. So we are following them. We are routinely doing the screening, especially gem traders. We are going to their mosque. We are going to their gem farm. Manipulakian, we go there and routinely we select these people and test. So these are the major strategies on how to prevent malaria. So the take-home message: never again malaria. You cannot afford malaria. Why? Because if you manage the patient before you get the outbreak, it's very low amount of money. But if you get the outbreak, there will be a huge cost of management you have to bear if you get an outbreak. So never again malaria, and we have to be responsible person. We are responsible person. So please be a responsible person. How? To prevent malaria by getting the drugs, and after coming, if you have any features of malaria, fever or headache or body aches, then you have to think it could be malaria. You have to say to doctor, doctor, I may be having malaria. That's enough. Then he will do all the things.
So, never again malaria. The story says prevention is better than cure. There is no other word about that. So I think we have come to the end of the presentations. Now it will be the question and answer session.
Very reluctant to go to the anyway, that at least you can, they will come there, at least without you taking their name, addresses, and all that. In our prescription, you can give this pre and post-exposure drugs. I think that will be a very good thing, because we get a lot of patients coming like that. But I don't think they because of the stigma and going there and sort of thing, or if it's available at Australia, if we can prescribe, I think, because I don't think the resistance will matter, because anyway, like, we want to treat everybody. So, I mean, like, the only history we are taking is that they are exposed. So if you can do something more for that, I mean,
Yeah. Thank you very much for the question. Actually, this post-exposure prophylaxis for high-risk sexual behavior, that option was started recently, I would say maybe 3 years back. But we have had a lot of requests about having it available in the private sector. We are having discussions about it, because at the moment we purchase or procure the drug through the campaign, then distributed also through the campaign. There are now about 4 suppliers who are trying to get registration with the NMRA also. So in future there may be, like private sector organizations, but we have to have a technical level decision where we are going to make it available. Only issue is that for post-exposure prophylaxis, at least a doctor, even a GP, has to prescribe it. And in terms of pre-exposure, there are 2 methods, like the regular daily dose as well as event-based. There are 2 options there also. What we have seen in our high-risk populations is sometimes they take the 30 tablet bottle and share it among their friends and take it as an event base. So these are the real situations that has caused this reluctance to make it freely available. There are clinical trials also about pre-exposure where you have injectable forms for like twice a year. So it's an evolving field. We are not, strictly saying it will not be available, but we are exploring, actually, due to the demand, exploring the possibility of having it in the open market through prescriptions. And you are correct, because of the stigma, people are reluctant to come to the STD clinics.
Patient come here, you take the identity card number, addresses, name and everything.
Registration, yes.
So we can actually educate the now in the PGIM we are having a lot of primary care, MD, family medicine and all those things, even college of general practitioners we are having so many courses, so we can educate the GPs not like those days.
Yes.
How to use it the proper way and doing all that. So I think because do you get patients coming like that?
Yeah, even to the Colombo clinic we get. Yes, but if it is a local, we give it free. If it is a foreigner, we take a reasonable charge and offer it. We have our even a Sunday clinic, and then we have starter packs in each hospital. We have the starter pack for, like, say, it has to be taken within 72 hours. So if it is a public holiday or a Sunday, you know, there's a risk that the clinic is not closed, not open. Some of the STD clinics are not open on Sundays and holidays. So we have kept the starter pack at the ETUs. So it's available and there are people coming. To our clinic, of course, they do
so
come.
They can go to a normal hospital?
No, yes, for the starter pack.
Ah.
Yes.
So they will, the medical officers,
Yes.
they are no?
Yes,
They are
yes,
being,
yes.
So they don't have to come to the STD?
STD clinic on the next working day, they have to come to the STD clinic.
Sellers, and if dossiers are given at the MRI approves and if it's available at even at those sellers, then we can prescribe.
Yeah, because it's beyond drug, you know, the medicine may be there, we have to do the testing and all. It's like, you know, it has to be evaluated properly, that's the only issue. But I think it will be available in future in the market. Yes.
There are a lot of professionals who are not the medical personnel. What do you expect?
Okay. Yeah, it's mainly the awareness and encouraging testing. Actually, as I also mentioned, these safe sexual practices and that age-appropriate sex education are things that are not discussed freely, and even among our the high-risk population, 15 to 24, they don't have much idea about safe sex, etc. So the organizations can promote and at the same time encourage testing. We can collaborate and provide the self-test kits or organize camps, etc. So that kind of a support is expected, and also referral to the clinic. Those kind of support is very much appreciated.
It is high. And then in your pie chart also you have given percentage wise because of that number is high. And then I need to know, have you done any research or whatever? Are there any correlation between the environment to the TB? Now, it is obvious that you have mentioned the prisons, of course, you know, you have high density like other HIV is coastal area or some other can say high risk. But I need to know whether any environment and the TB has some correlation between those two.
Yeah, it's better to do this type of researches about this. Thank you very much.
Dr. Pravita, it is already known, isn't it? The overcrowding,
Yeah.
the malnutrition, those
Main thing, and the smoking is another thing, and there are drug users mainly in Colombo district and the Western province mainly, and those are the main behaviors, and the comorbidities. Then diabetes is the main cause of reducing the immunity of the people. All the people who are going to the who are having diabetes, they can test for the tuberculosis. That is the main.
In Colombo, and there are 6 consultants in our campaign also. We also do, but more than that, it's through the districts. We do the master trainer programs, and our consultants do the master training, and it's kind of a cascade training. So if there are factories, etc., at district level, they are doing actually. They do programs in factories, vocational training institutes, universities, prisons, etc. So all are coordinated by the district consultant venerologist.
any member of the society. It may be a doctor, it may be another professional, or even a young person, volunteer. What are the roles of the members of the society as a whole in prevention of tuberculosis?
Yes, thank you. I think the awareness is most important about the having tuberculosis. If the person has signs and symptoms of tuberculosis, that means cough and things, and weight loss and low-grade fever, sweating at night, so many things, we can refer these patients to we can inform the patients to go to the nearest case clinic. Better if they can go to the case clinic or to the outpatient department, they can go there and get the investigations there. And also we want to inform all the general practitioners also. We have informed them to refer these patients to the hospital or the test clinics for the investigations, for the screening. That's the first thing. And also, if tuberculosis is also another stigmatic disease, because if if there a person having tuberculosis, other people that they don't like to go to these patients' houses and they don't like to contact with them. Usually we are the people giving free of charge treating the patients. You can't get the treatment from the outside. You have to go to the hospital or the test clinic for the treatments. And these people, as I mentioned earlier, they need some help. Usually after treating 2 weeks, they get the infection is reduced. They can go for the work and they can do their activities, but they need to take treatments at least for 6 months. During that period, we need to help them. If you can give some thing, if you can give some money or something, it's better. If you can arrange that type of things, if we can give some food back to that people or something. We can help their children and things. If you can do this thing, it's better. I think that is the most important thing that we hope from you.
For your informative presentation, it came in the news today. Actually, you mentioned it in your presentation also that HIV is on the increase. And also in the news bulletin they said that it is among the mainly among the teenagers. So my question is it because of homosexualism? And number two, because of use of narcotics. Is there any connection?
Sometimes 20 to 24, the age group, we get their history, but we don't divulge it openly about their sexual behavior because we are bound to have the confidentiality. So, although we analyze as aggregated data, we can't divulge it. Behavior, but we mainly think as the reason is that with the use of new technology, mobile phones, various dating apps, etc., they look for relationships, not like earlier days, like one partner relationships are less common at this age. They go for multiple partners. Maybe there are associated drug use as well. And it's through the technological devices, etc., they look for these partners, maybe casual relationships. So that is what we hypothesize. So that could be the reason why it's increasing in that age group.
Haven't you analyzed the situation and found out the exact reason?
We have analyzed, but sometimes we don't disclose it very openly.
In identify the travelers who are going to these countries, especially although we are just doing many awareness programs among the public on the importance of getting the drugs. Because yes, there are many other methods using repellents, sometimes wearing some long sleeve clothes, but they are not practical at all. But the main issue is that especially the prophylaxis, there are lots of myths among specific groups on having this prophylaxis. Because most of them are thinking that these are affecting their behaviors and but like this myths. So it's very difficult us to convince some certain groups who are frequently going to these countries on the importance of getting the prophylactic drug. So we just do some kind of many other methods on also improving their awareness, and because we have distributed our leaflets and others through many methods of communication to them that the drugs are free of charge. The drug is costly drug. One tablet is around 1,000 rupees, and if they go for 1 year, we are giving 60,000. We are giving drug for 60,000 for single person, free of charge. But still, people, there is some kind of hesitancy to just get the drug. So yes, from our side, we are trying our best to increase the awareness of importance of drug. It has been increased, and we know that we gave these drugs to a peacekeeping mission. So what they say that only their camp, only the officers in their camp are saved from this malaria. All the other tribe forces around the camp came from Korea, USA, they all got malaria, but our people just did not get in, single person didn't get malaria. So that's why I am always asking, this is a very good drug, this is a very safe drug, but you have to come in advance and get the drugs.
What I mentioned was, is there a way of doing some social marketing? Because today internet is used a lot, like social marketing. We are traveling abroad to these countries, go and consult the anti-malaria and take it.
Yes, because we have some WhatsApp groups, because they are in certain WhatsApp groups. So we just also got the membership of the WhatsApp groups, and we are frequently putting the message of the importance of getting these drugs. Yes, after these WhatsApp messages and this social marketing campaign, the intake of prophylaxis has been increased. Even sometimes in the weekends, the people specifically come and just ask the drugs before they go. Yes, we are seeing an increase, but still it's not the optimal level of requesting the drugs. So especially if you are managers, if you are having some communication with the people who are going to these African countries, especially for this garment sector. There are lots of garments out in African countries where the members in Sri Lanka, the people go there and work there for 1 year, around 1 year. So if you can spread the message, please get the prophylaxis drug from the area, that is more than enough. That is the thing. So routine testing, the testing at the airport, not cost effective at all, because there will be lots of negatives. So the main thing is, if you travel to a country and for last 1 year, if you get fever or any other disease, then
HIV is the virus, AIDS is the after some years you lose the immunity, and that's the disease with symptoms.
I also coming to Sri Lanka, enormous. So should they test when they come, or I mean, is there a need to test, or what extent is this risk to be evaluated?
Chennai is free of malaria, yes, but very lesser number of people getting malaria when they go to Chennai. But there are some states in India, we get malaria, especially Mumbai and others. Usually we get patients. So whenever if a person goes to India and come, yes, it is not it is not recommended to do it routinely. But the issue is we don't know whether he has got malaria, because if he has gone to Mumbai, even Chennai, we don't know, because still the patients are getting from Chennai. So we don't know he was infected. So major thing is, test is free of charge, very simple. So doing a test, if you have features, and in one slide I just didn't show, that slide very clearly show, if you have features of malaria, then getting it positive is very, very high. That means within one year after coming to Sri Lanka, even though you go to Chennai, it is advisable to get it done.
Questions and answer session. I think finally, as a moderator, I would like to appeal that this should not end from here. Please educate and please make your members aware. You all are the representatives of your member organization. So please make them aware.
As the country faces a great threat to public health due to these diseases, I'm sure that what we have learned today will be of great benefit to all of us, particularly in terms of the support we can extend as professionals by spreading awareness and informing those around us. So I would like to extend my sincere appreciation to Dr. Vindhya Kumarapeli, Director National STD and AIDS Control Program, Dr. Pramita Shantilata, Director National Program Tuberculosis Control and Chest Diseases, and Dr. Pubudu Chulasiri, Consultant Community Physician, for being our guest speakers this evening. Thank you. I also would like to thank Dr. Kanti Ariyaratne for moderating this seminar. We have all learned a great deal from you, from your insights and expertise. I must thank Dr. Hasari of the Independent Medical Practitioners Association for jointly organizing this event with us. I would like to also express my gratitude to the Country Coordinating Mechanism Sri Lanka for sponsoring today's event. Thank you, ma'am. My appreciation goes to the Presidents, Mr. Sujivalal Dahanayaka, President-elect Mr. Jayanta Gallaheva, Treasurer Mr. Chandasiri Kalupahana, for their leadership and guidance. And also I would like to thank the Center Director and staff of OPA for all the support extended. Finally, I would like to thank the audience for your active participation. Now I invite everyone for dinner at the restaurant. Thank you.